My name is James Randall. I'm PGY3 at Northwestern. I'll be talking about the MR-Linac that we are bringing to our program, sort of how we prepared for that, and also analyzing the educational curriculum that we instituted during this whole process. As many of us are aware, instituting an MR-Linac causes a lot of changes in the program. It's changes with how you plan radiation, how you implement radiation, and also how you teach radiotherapy planning. For physicians and residents, it requires doing abdominal structures, especially in pancreatic cases, which are really common for MR-Linacs, on MR imaging, especially on low field images like you can see here. They're often very fuzzy and not as clear as higher powered fields like 3 Tesla. It also causes residents and physicians to learn how to look for changes on targets on MR imaging, and also changes in workflow for physics and dosimetrists because they no longer have their typical CT-based workflows to rely on. And then on the machine itself, when you're doing adaptive treatments, there's a really high time constraint because the patient is sitting on a table waiting for the adaptive treatment. So the physicians and residents who are involved have to quickly do this process. They have to quickly identify critical structures and do target delineation at the same time if it requires adaptation. Also, it requires a lot of changes for radiotherapists, given the safety that's different. There's different considerations that go into MR fields versus CT-based safety protocols. So overall, the preparation for this, or the purpose of this project was preparation of our department. It's something I was passionate about, even as a medical student, reading about MR-Linacs. The potential for margin reduction was something I was really interested in. So it's a personal passion of mine. And I also wanted to help educate my co-residents and our radiation therapists and help prepare our department in general to receive and implement this machine. To do so, we created a curriculum that was tailored to both radiotherapists and radiation oncology residents. We were mostly just looking at feasibility of implementing this curriculum and looking at how radiotherapists and residents' volumes change from pre and post education, and also what their experience was with some pre and post surveys. So our methods, this was an IRB approved study at our institution. It recruited radiotherapists and residents. There was a pre-education baseline MR volume where we gave a few series to both radiotherapists and residents and had them do volumes before they learned anything about abdominal imaging or radiotherapy on MR-Linac. And then the intervention itself was the tailored education that was specific to either radiotherapists or residents. These included didactic sessions, hands-on demonstrations, self-study material, and volumetric feedback in the case of radiotherapists because they had never done this before. So they were slowly learning over the course of 6 cases to learn how to do basic OARs like lungs, hearts, kidneys, etc. And the ultimate test was the post-education MR volumes, looking at how well they did or how much worse they did compared to their pre-education MR volumes. And you can see the OARs that we requested on the right there. So for radiotherapists, they had some pretty basic OARs, and the residents had more critical OARs as if they were doing a pancreatic plan. So this is a quick schematic. I'm a very visual person. I feel like this might help, but we had a gold standard that all cases were compared to, and that was a physician delineated gold standard. The radiotherapist, as you can see, did one case, and then they moved on to the next case in a sequential manner with some education between given by the attending physician, who was Dr. Thomas at our institution. And the residents had a much more classical pre and post education assessment where they did several cases, then got educated, and then did those same cases post education to assess changes. Our overall results, we had 5 radiotherapists who were involved, who will be treating on the machine, who took part in this study. And we had 6 residents who were recruited for a total of 11 participants. Of the total 270 requested radiotherapy volumes, 220 were completed for 81.48% completion. And of the total 180 resident volumes, 179 were completed. There was only 1 volume that was left uncompleted. This is a quick overview of the data. So you can see this is a graph depicting the radiotherapy volumes, looking at the average DICE similarity coefficient by each case. So remember, these were sequential, so there should be improvement from case 1 to case 6. However, if you look at the overall trend line for all of the OARs, there really was no significant improvement. The interesting thing is that when we dive deeper into the stats, you can see some cases of improvement per person, which is good to see. And you can also see some cases of improvement per volume. So they got much better at the liver or the stomach, for instance, over time. However, on average, there was really no improvement. The interesting thing for residents, though, is that there was some pretty good improvement. You can see on the graph here, similar comparison of DICE similarity coefficients to the gold standard for pre-education volumes on the left, and then post-education volumes on the right. Again, this was the stomach, duodenum, CBD, small bowel, and large bowel. You can see at the very top, the stomach looks really good to start with, and there really was no overall improvement from pre to post, which is fine. And then the CBD on the bottom down there in the green had some pretty poor performance to start, but there was significant improvement in the post average. So you can see that the overall percent increase was 35.18% increase in similarity to the gold standard volumes after education, which is nice. So in summary, this was a medical education feasibility trial regarding implementation of an MR-Linac in our radiation oncology department. Radiotherapists and residents were recruited with 75% participation of the resident cohort, which is good to see. This was completely voluntary. The educational course and volumetric sampling was found to be feasible. Participation after recruitment was 100%. Completion of all required volumes ranged from 57.4% to 100% per individual. RT volumes have good baseline correlation to standard, which is good to see so that they can help contribute to radiotherapy planning on the machine. And resident volumes have improved correlation to standard after education. Volumetric and survey analysis is still ongoing, so hopefully we can dive into those details and see which organs were problems and which ones look good. So overall, thank you for your time. I really appreciate it. I have started looking at the surveys. My feedback so far was that contouring valve takes a long time. Thank you for your time. Thank you to Dr. Thomas, and thank you to Quinn and the dog.